I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. Hello, welcome to a bonus episode of Prescribe or Pass the Pop Pod. I thought our ADHD series was finished, and then on the 24th of July 2026, the FDA approved a completely new ADHD medication. It's called Centanafadine, brand name Simtriyo, and pharmacologically it's interesting because it doesn't fit neatly into the categories we've spent the rest of this series discussing. Centanafadine inhibits the reuptake of noradrenaline, dopamine, and serotonin. That makes it the first FDA-approved noradrenaline, dopamine, serotonin reuptake inhibitor, or NDSRI, for ADHD. It has been approved in the United States for adults and for children aged 6 years or older who weigh at least 20 kilograms. So this is a short bonus episode. What is Centanafadine? How is it different from the ADHD medications we already use? Why add serotonin to the equation? Is it a stimulant or a non-stimulant? How effective does it appear to be? And what do clinicians need to know about the safety profile? Importantly, this is a newly approved American medication. It is not a treatment option in Australia, and at time of recording, I can't find any evidence of an application for TGA registration in Australia, so we don't yet know whether or when it might become available here. First, a very quick ADHD pharmacology refresher. Throughout this series, we've talked repeatedly about dopamine and noradrenaline, and that's because most ADHD pharmacotherapy ultimately influences one or both of those neurotransmitters. Methylphenidate blocks dopamine and noradrenaline reuptake. Amphetamine-based medications such as dexamphetamine and lisdexamphetamine increase catecholamine signaling through somewhat different mechanisms. Atomoxetine is primarily a noradrenaline reuptake inhibitor. And then we have the medications such as guanfacine and clonidine, which work through the alpha-2A adrenergic receptors rather than directly inhibiting monoamine transporters. Centanafadine adds something different. It binds to the noradrenaline transporter, dopamine transporter, and serotonin transporter, NET, DAT, and SERT, and inhibits the reuptake of all three neurotransmitters. The FDA label is careful to say that the precise mechanism through which this treats ADHD remains unclear, but its efficacy may be mediated through this triple reuptake inhibition. Think of reuptake transporters as the recycling systems sitting on the presynaptic neuron. After a neurotransmitter has been released into the synapse, these transporters help pull it back into the nerve terminal. Block the transporter and more neurotransmitter remains available within the synaptic space. So Centanafadine increases signaling involving noradrenaline, dopamine, and serotonin. Well, why serotonin? And this is probably the most interesting question, because if dopamine and noradrenaline are the classic ADHD neurotransmitters, why bother adding serotonin? One answer is that ADHD is more complicated than simply not enough dopamine. Attention, impulse control, reward processing, motivation, and executive function involve multiple interacting neural networks. Serotonergic pathways also interact extensively with dopaminergic and noradrenergic systems. It would be very tempting to say, serotonin. Therefore, centanafadine must also improve anxiety, mood, or emotional dysregulation. We can't assume that from the mechanism alone. Otsuka has reported positive top-line results from a separate phase 3B study in adults with both ADHD and anxiety, but those findings don't automatically mean centanafadine should be considered an antidepressant or anxiolytic. Mechanism generates a hypothesis. Clinical trials tell us whether those hypotheses actually matter to patients. Is centanafadine a stimulant? Here's where things become particularly interesting. During its development, centanafadine was frequently described as a potential non-stimulant ADHD medication. And mechanistically, it certainly looks different from traditional amphetamine and methylphenidate stimulants. But the FDA-approved product information now explicitly describes Simtriyo as both an NDSRI and a central nervous system stimulant. The US label contains a boxed warning regarding abuse, misuse, and addiction, and the controlled substance schedule is still to be determined following review by the US Drug Enforcement Administration. There have also been human abuse potential studies. At supratherapeutic immediate release doses, centanafadine produced measurable drug-liking and euphoric effects. The FDA therefore concludes that centanafadine has abuse potential. Remember though, abuse potential, addiction, and physical dependence are not the same thing. In 2 adult phase 3 studies, abrupt discontinuation produced very low levels of withdrawal symptoms that were indistinguishable from placebo, suggesting little evidence of physical dependence in those trials. So this is already a good example of why labels such as stimulant and non-stimulant can sometimes conceal more pharmacological nuance than they reveal. What does the evidence actually show? The FDA was supported by 4 pivotal phase 3 trials covering children, adolescents, and adults. In children aged 6 to 12, the effective weight-adjusted dose produced a statistically significant improvement in ADHD rating scale scores compared with placebo after 6 weeks. The placebo-adjusted difference was approximately 5.6 points on the ADHD RS5. In adolescents aged 13 to 17, the 280 milligram dose also significantly improved ADHD symptoms, with a placebo-adjusted difference of approximately 4.4 on the ADHD RS5 at 6 weeks. The adult evidence came from 2 6-week placebo-controlled trials involving just over 900 participants combined. Centanafadine significantly improved scores on the Adult ADHD Investigator Symptom Rating Scale, or AISRS. Depending on the study and the dose, the placebo-adjusted improvement was roughly 2.7 to 4.4 points. Clinical Global Impression Severity scores also improved significantly. So, yeah, it works better than placebo. But one important thing is missing. These pivotal trials were not head-to-head trials against methylphenidate, lisdexamfetamine, or atomoxetine. So FDA approval tells us that centanafadine is effective. It does not tell us if it's superior to existing ADHD medication. That distinction is crucial whenever a genuinely novel drug arrives. New mechanism does not automatically mean better drug. What about dosing? Simtriyo is an extended release capsule given once daily in the morning. For adults, the recommended starting dose is 210 milligrams once daily, increasing to a maximum of 280 milligrams, depending on response and tolerability. Adolescents aged 13 to 17 received 280 milligrams once daily. Younger children were dosed according to weight. The capsule can either be swallowed whole or opened and sprinkled over applesauce or yogurt or mixed with a small amount of orange juice. And there is an interesting formulation detail here. The capsule contains a combination of immediate release, extended release, and delayed release beads designed to produce its once daily profile. Peak plasma concentrations occurred at around 5 hours, and the mean elimination half-life is approximately 5.2 hours. What are the adverse effects? The common adverse effects look similar to ADHD medication. In adults, they include headache, reduced appetite, insomnia, nausea, dry mouth, and diarrhea. In children and adolescents, decreased appetite, nausea, headache, abdominal pain, and rash were among the commonly reported effects. Blood pressure and heart rate can increase, so these should be assessed before treatment and monitored during therapy. The label recommends avoiding the medication in people with serious structural cardiac disease, cardiomyopathy, serious arrhythmias, or other significant cardiac disease. There are familiar stimulant warnings around psychosis or mania, growth suppression in children, peripheral vasculopathy, including Raynaud phenomenon, and worsening of tics or Tourette's syndrome. But because centanafadine also affects serotonin, there is another important consideration: serotonin syndrome. Using centanafadine along with other serotonergic medicines may increase that risk. Monoamine oxidase inhibitors are contraindicated, including within 14 days of stopping a monoamine oxidase inhibitor, and clinicians will need to consider concurrent serotonergic medicines such as SSRIs and SNRIs rather than assuming this behaves exactly like methylphenidate or dexamphetamine. There is also a boxed warning regarding suicidal ideation and behaviour in paediatric patients. In a 6-week study of children aged 6 to 12, suicidal ideation and behaviours were reported more frequently with centanafadine than placebo, so the FDA recommends close monitoring of paediatric patients. That deserves to be taken seriously. So where might centanafadine eventually fit? That is the question we can't really answer yet. The attraction is obvious. It provides a genuinely different pharmacological approach and therefore potentially another option for patients who do not obtain sufficient benefit from existing therapies or cannot tolerate them. But we don't yet have the decades of clinical experience that we have with methylphenidate or amphetamines. And we certainly don't yet have the evidence showing that clinicians should abandon treatments that are already highly effective for many people with ADHD. In pharmacotherapy, having another option is valuable precisely because patients are different. One person does beautifully on methylphenidate, another responds far better to lisdexamphetamine, another cannot tolerate stimulants at all, and another does well with atomoxetine or guanfacine. Centanafadine may eventually give clinicians another lever to pull, but we need comparative trials, real-world experience, and longer-term safety data before we know exactly where that lever belongs. And one final pharmacological point, you might reasonably ask, if centanafadine simply increases noradrenaline, dopamine, and serotonin, couldn't we just combine existing medications that affect all those 3 neurotransmitters? For example, a dopamine and noradrenaline reuptake inhibitor with an SSRI or SNRI. But pharmacology doesn't work quite like adding ingredients into a shopping basket. A single molecule has its own relative affinities for DAT, NET, and SERT, its own concentration time profile, its own distribution within the nervous system, its own metabolites, and its own downstream physiological effects. 3 neurotransmitters affected does not mean 3 interchangeable pharmacological effects. And that is probably a discussion worthy of an episode in itself. Some reflective questions. Can I explain why centanafadine's triple reuptake inhibition is pharmacologically different from simply combining existing serotonergic and catecholinergic medicines? When I hear that a new ADHD medication has a novel mechanism, do I separate novelty from evidence that it is actually superior to existing treatments? How would the serotonergic activity of centanafadine change the way I review a patient's existing medication list? What monitoring would I consider before and during treatment, particularly regarding cardiovascular effects, appetite, growth, and psychiatric symptoms? Can I explain why centanafadine may look mechanistically different from traditional stimulants while still being classified by the FDA as a central nervous system stimulant? Centanafadine is genuinely interesting, not because it's necessarily going to replace the ADHD medications we already use, but because it gives us a new way of manipulating neurotransmission in a condition where individual response to medication can vary enormously. And for clinicians, another evidence-based treatment option is generally a good thing. Thanks for listening to this bonus episode of Prescribe or Pass, the Pop Pod.